And most importantly, it's not a magic treatment picker, and it is definitely not a replacement for doctors. Instead, AI may become something more useful. Think of it like a weather forecast. Not because cancer is simple or predictable like the weather, but because both forecasts express uncertainty. An 80% chance of rain is not a promise that rain will fall on you. In the same way, an AI prediction would not promise that a treatment will work for the person, but it could help estimate which option is more likely to help using patterns from many previous patients. And that matters because two people can appear to have the same cancer, receive the same medicine, and have completely different outcomes. One person's tumor may shrink, while the other person's tumor may barely respond. So, what clues could AI use to tell those two situations apart? Could it combine information from blood tests, scans, tissue slides, genes, and past patient outcomes before treatment even begins? In the past, treatment choices were often based mainly on where the cancer started, for example, breast, lung, bowel, or prostate. That information still matters enormously. But now doctors also ask deeper questions. Does the tumor carry a particular mutation? Does it make a protein that a drug can target? Are there signs that the immune system may respond to immunotherapy? Has the cancer already developed resistance to a previous treatment? And what matters most to the patient? For example, some treatments may offer a higher chance of response but also more serious side effects. So, treatment choice is never just about a tumor, it is about the tumor and the person living with it. Think of cancer treatment like choosing the right key for a lock. The lock may look similar from the outside, but the pins inside can be very different. A key that opens one lock perfectly may not turn at all in another. AI is being explored as a way to inspect more of those hidden pins before treatment begins. A person's cancer can generate huge amounts of data. First, there is DNA, which can show mutations, changes in the tumor's genetic instructions. Some mutations are important because they make a tumor vulnerable to a targeted drug. And then there is RNA. If DNA is the instruction manual, RNA tells us which parts of that manual are being actively read. In other words, RNA can give us clues about what the tumor cells are doing right now. Then there are proteins. Proteins are the working machines of a cell. They can tell us whether a treatment target is actually present or whether the tumor is using a pathway that helps it grow. Then there are pathology slides. These slides reveal what the tumor looks like under the microscope, how its cells are arranged, how aggressive it appears, and how immune cells are distributed around it. Then we have scans. CT scan, MRI scan, PET scan, and others can show where the cancer is, how large it is, and whether it is changing over time. And then there are regular blood tests, medical history, previous treatments, and outcomes from patients treated in the past. To be honest, that is a lot of information. For a human, it can be like trying to read 10 books at once while also deciding which sentences matter most. AI may help by bringing those books together and looking for patterns across all of them. One easy way to imagine it is as a very large library. Every book in this library tells the story of one patient. their tumor type, their blood test results, their molecular test results, their treatment, and what happened afterwards. Did the tumor shrink? Did it stop growing? Did it become resistant? Did the patient experience serious side effects? AI studies many of these stories and looks for patterns. Then, when a new patient arrives, it asks which previous patients had a similar pattern. Maybe it finds that patients with a particular mix of blood markers, tumor features, and clinical history often benefited from a treatment. Or it may find that a certain pattern was more often linked with treatment resistance. This does not mean AI knows the future. It means AI can calculate a probability based on previous available data. Just like a weather forecast, it can be useful without being certain. One research example is a model called Scorpio. Scorpio was developed to predict outcomes in patients receiving immune checkpoint inhibitors. These are immunotherapy drugs. They work by helping the immune system recognize and attack cancer cells more effectively. But immunotherapy does not work for everyone. Some people have dramatic, long-lasting responses. Others get little benefit. So researchers are looking for better ways to predict who may respond. Scorpio is interesting because it uses routinely collected clinical information, including blood test results, such as blood cell counts and metabolic blood markers. In simple language, it asks whether ordinary information already present in many hospital records might hold useful clues about immunotherapy response. Scorpio was developed using data from 9,745 patients across 21 cancer types who received checkpoint inhibitors. That is important because it suggests prediction tools may not always need the most complex or expensive tumor test to find useful patterns. But this does not mean a routine blood test can now tell every person whether immunotherapy will work or not. Scorpio is still a research model. It needs continued validation in real clinical settings before it can guide routine treatment decisions on its own. A second research example is called perception. Perception takes a different approach. It looks at gene activity in individual tumor cells using a technique called single-cell RNA sequencing. Now, that may sound technical, but the idea is actually very simple. A tumor is not one identical lump of cells. It is more like a busy city. Some neighborhoods may be highly sensitive to treatment, whereas other neighborhoods may be growing very quickly. And a small group of cells may already have the ability to survive a drug. Those resistant cells can actually matter a lot. Even if most of the tumor responds, a few resistant cells may survive, multiply, and eventually allow the cancer to grow once again. Perception tries to study these cellular differences. It aims to predict which drugs may be more effective against the tumor and which treatments may be more likely to face resistance. The model has been evaluated using data sets from multiple myeloma, breast cancer, and lung cancer. Think of it like listening to a crowd. If you only listen from far away, you hear one big sound. But if you give every person in the crowd a microphone, you start to notice that different groups are saying very different things. Single-cell RNA sequencing gives researchers something closer to those individual microphones. Imagine a patient whose cancer could be treated with several possible options. Doctors will still begin with the essentials. What cancer is it? How advanced is it? What validated biomarkers are present? And what treatment has the person already received? What side effects can they reasonably manage? And what does the patient want from the treatment? Then AI could potentially add another layer. It could combine information from blood tests, pathology, scans, tumor genetics, and outcomes from similar patients. Its output might look something like this. Treatment A, more likely to help. Treatment B, uncertain. Treatment C, pattern linked with early resistance. That could help the clinical team ask better questions. Should we run an extra test? Should we monitor this patient more closely? Could they be eligible for a clinical trial? Is there a combination treatment worth investigating? Again, the AI is not choosing the treatment. It's helping doctors decide where to look more carefully. AI should not replace validated biomarkers. A validated biomarker is a test that has been carefully studied and shown to help guide treatment in a particular cancer setting. For example, some tumor mutations or protein markers are already used in clinical care because they have strong evidence behind them. AI may add useful information now, but it should sit alongside these tests, not push them aside. There are also practical challenges. An AI model may work well in one research dataset but perform differently in another hospital. Why? Because hospitals may use different scanners, laboratory tests, patient populations, record systems, and treatment pathways. And then there is the human side. AI cannot truly understand what matters most to a patient. It cannot understand fear, family responsibilities, work, travel, religious beliefs, previous experience of illness, or what level of side effects a person is willing to accept. That is why the final treatment decision must remain a human decision. It should involve the patient, oncologist, pathologist, radiologist, specialist nurse, and the wider multidisciplinary team. And that's being said, AI can still be a powerful assistant, but it should never become an unchecked decision maker. Systematic reviews of AI in digital pathology report promising accuracy, but also emphasize the need for more rigorous evaluation before broad clinical adoption. So, can AI pick the right cancer treatment? Not by itself, but it may help doctors make better, more informed decisions by combining clues from genetics, RNA, proteins, tissue slides, scans, blood tests, and previous patient outcomes. The goal is not to replace doctors. The goal is to give every patient the best possible chance of receiving the treatment that fits their cancer and their life.